Good morning, everyone, and welcome to another in our series of Faith and Health webinars, today hosted by Church Health. My name is Joshua Narcis, and I am glad to be able to say I work at Church Health with our Faith Community Engagement team and will be moderating today's conversation with Dr. Kendra Hotz. Today, we will be talking about racism, health, and healthcare. There have been a few moments in history that have presented us with such a confluence of realities that have always been interconnected, but now force us to deal with the hard and troubling truth that racism does have an impact on our healthcare system and broadly the health and well-being and lives of all people, particularly Black and Brown, Indigenous, and people of color of all walks of life. So today we will begin what is part of a two-part webinar series to begin to unpack the intersections between racism, health, and healthcare. Today we are led by Dr. Kendra Hotz. She will begin to frame this conversation, lay the foundations, and point us in the direction when 2 weeks from now, on Thursday, September 3rd at 11:30 a.m., we will be joined by a panel of practitioners and clergy members who will continue this conversation, offer their thoughts, some solutions, and just their hopes for where do we go from here. But today, as I said, we will be led by Dr. Hotz, Dr. Kendra Hotz, who is the Associate Professor of Religious Studies and the Robert R. Waller Chair of Population Health at Rhodes College. She teaches courses in theology, ethics, Africana studies, and urban studies. Dr. Hotz is co-author of a number of books and articles. I will not read the entire list, but her research focuses on the relationship between religious belonging, social inequalities, and health. To highlight just a few of those many works, she is the author of the book Dust and Breath, Faith, Health, and Why the Church Should Care About Both, and journal articles, Big Mama Had Sugar, I'ma Have It Too, Medical Fatalism in the Language of Faith Among African American Women in Memphis, as well as I Can Do For Me, Race, Health, and the Rhetoric of Self-Love and Suffering. In addition to all of these things, as well as being our guest this morning, Dr. Hotz is an avid transportation cyclist who lives in downtown Memphis with her spouse Matt, and their dog, Argos. It is indeed a pleasure to be able to have Dr. Hotz join us as part of this conversation. And without any other further comments, I will turn it over to Dr. Hotz for the remainder of our time together. I will just continue to highlight that if you do have questions, we will have a question and answer session after Dr. Hotz's presentation. Please submit your questions via the question and answer function in Zoom, not the chat feature, and we'll make sure to get to them after the presentation. Dr. Hotz.
Thank you so much. Hello, everyone. I am thrilled to be with you today. The first most important thing you may notice is that I do not look like the picture that was just posted. That was many months ago, and I haven't had a haircut in 5 months. I'm sure many of you are feeling sympathy with me for that. I'm happy to be with you today, and what we're going to do is talk about how health is a social production, how health and disease are made for us by social injustices and by work for liberation. And I think that the ways in which this translates for the life of faith will be really just abundantly clear. For me, the title slide here names why this is about the gospel. It's because you can measure the justice of a society really in quite literal ways in the bodies of its people. And when you think about Jesus' ministry of healing and preaching and teaching, we sometimes imagine that those were three separate things. But in fact, I think that Jesus is proclaiming the gospel both in word and deed. And what we're going to see here is the ways in which the structures of our world prevent the gospel from being experienced in bodily ways. And what we'll have to do is think together about how we change that. So let me start by showing you what we mean by health disparities and health equity. 3 quick examples. First one is you're looking at a slide. This is data from the Shelby County Health Department about life expectancy in 2 zip codes right here in Shelby County. 38106, that is the area downtown around Soulsville, and 38017, that's a far-flung eastern suburb, Collierville. It's about 26 miles between Soulsville and Collierville, and a 13-year life expectancy gap between those 2 locations. What that means is that you're gaining a half a year of life for every mile you move east. And if you think about the differences between those 2 zip codes and what changes as you traverse the space from one to another, you can probably account for that yourself. And that tells you that you already know what a social determinant of health is. You see different kinds of grocery stores. You see differences between a bank in one location and a pawn shop in another. You see differences in transportation infrastructure, access to healthcare. You also see differences in the size and quality of the housing stock. And here in Memphis, one of the most striking things you'll see is that the city goes from black to white as you move east, and it moves from poor to affluence as you move east. And we're going to explore in a little bit the racialization of poverty and why that's so important for health. So our first social determinant of health here is simply neighborhood. The neighborhood you live in will shape your health. A second social determinant of health is socioeconomic status, and these, of course, are closely related. What you're looking at here, the bottom there, the x-axis is household income, and then the y-axis is prevalence of type 2 diabetes. And you see that perfect stair stepping? What it tells you is that we have a health-wealth gradient, that the wealthier you are, the healthier you are. You're almost twice as likely to, actually in this case, it's 3 times as likely to have type 2 diabetes if you're low income as if you're high income. So your socioeconomic status is also a social determinant of health. And by the way, studies like this showing this health-wealth gradient have been replicated hundreds of times in dozens of locations. It started in 1968 in Whitehall, England. This is data from 2016. And every time we replicate studies like this, looking for a relationship between health and wealth, we find this same dynamic, that the social hierarchies produce hierarchies of disease. Third, let's think about racialized identity as a social determinant of health. Please notice that I am not saying race. I used to say race is a social determinant of health, but that's not true. It's not who you are. Race is not a biological reality. It's a social and political reality. And so rather than having a race, we are racialized. So I am very likely legible to you as white. You might be legible to me as Black or brown. You might be legible to me as Asian or Hispanic. That means our identities are racialized. This is not about who we are. It's about who we're read as by each other. Okay, so here we're looking at education and racialized identity. And I'm going to revert and just keep talking about health and wealth because education and wealth are so closely indexed in the US. So I hope you can see my mouse moving across this slide. Here, the blue bar, this is a confusing graph, but we're just going to look at black and white. So the blue bar is white women who have experienced the death of an infant between birth and 1 year of life. And here on the far left, you see high school dropouts. Here you see those who have got a high school diploma. Here you see white women who have completed some college. And here you see white women who have dropped out of college. Now the orange line, we're looking at African Americans. So Black women who dropped out of high school, who completed high school, who have some college, who completed college. So within the white community, you see a health wealth disparity, and within the Black community, you see a health wealth disparity. But the gap between them is staggering. I don't know why my slide did that. Is staggering, this difference. And here's what's even more striking. Take your eye and just sort of go across the screen from the white woman who dropped out of high school to the Black woman who completed college. And you find that the Black woman who completed college has only a marginal advantage over the white woman who dropped out of high school. This is about whether our children live or die. And that Black woman, this is somebody like Serena Williams, who completed college, who understands how to take care of herself during pregnancy, who very likely chose to become pregnant, is financially stable, has all of the advantages that come with a college education and the sort of secure employment that often goes along with it. And she has every reason to expect a good birth outcome. But her infant is only marginally more likely to survive its first year of life than that white woman who dropped out of high school. For a while, people thought, well, maybe this is a biological difference. Maybe Black women simply have this kind of biological predisposition to premature births, which leads to infant mortality. So medical anthropologists studied that, and what they discovered is that women who immigrate to the US from the African continent, Black women who come from Africa to the US, have infant mortality rates that look just like their white peers. And their daughters, Black African girls born and raised in the US, have infant mortality rates that look just like their African American peers. In other words, just one generation makes the difference. And that tells us it's not genetic, it's not biological. What's really happening here is that racism is producing conditions that cause infant mortality. And I'll show you how that works in just a minute. So another thing that produces health disparities is medical racism. And here we're thinking about the ways in which the quality of care that we receive in healthcare settings will mean that we get different outcomes. So Black men are more likely to be recommended for amputations rather than the sorts of surgeries that white men would receive. African Americans are less likely to receive adequate pain medication. And there's been some studies showing that medical students have all kinds of really strange ideas about what they think are biological differences between white and Black. So for instance, medical students often believe that Black people literally have thicker skin than white people do, and therefore a reduced pain sensitivity. It's a bizarre idea, but it's still sort of out there in circulation. Here I've got two examples of medical racism. The one on the left is the sort of overt thing that we think of when we think of racism, but it's really the least of our problems. This is a picture of Governor Northam, who is currently the governor of Virginia. This is his medical school yearbook picture. I don't know if he's the guy in the blackface or the guy in the Ku Klux Klan thing, but either way, this is, think about it. These are, I think this is 1968, graduates from medical school. So these are the people who have been, the most prestigious, the most regarded as having expertise in medicine for a really long time. And this was considered so normal that they published it in the yearbook. I have a few more recent examples of things that are just as appalling. On the right, you're seeing something that's a much subtler form, though it's not really subtle, a much subtler form of medical racism. This is cultural competence training for nurses. This was published in 2017, so just 3.5 years ago. And what it's doing is proposing kind of bullet points, things you need to know about people who are culturally different in order to manage their pain. So notice that it lumps Arabs and Muslims together, which is weird because most Muslims are not Arab and not all Arabs are Muslim. It lumps all Asians together as though being from very far south on the Indian subcontinent is the same as being from northern China. Blacks couple of bullet points there. It's probably too small for you to see, but essentially it says that Black people are likely to exaggerate their pain. It says that Jews are vocal and demanding, that Native Americans are likely to pick a sacred number if you ask them how much pain they're in a scale from 1 to 10. This is just completely appalling. It's totally made up. The footnotes down there, I'm confident, are respectable academic sources that don't actually say what's summarized in the bullet points. What's always most striking to me is that there's no white on the page. There's no set of bullet points, things you need to know about white people to manage their pain. The assumption here is that white people simply report their pain in factual ways. And you can see how that's going to produce all kinds of disparities based on clinical determinants of health disparities. All right. Now, what I want us to do is go back to those social determinants of health and ask, why does that happen? Why does low income produce diabetes? Why does a racialized identity produce infant mortality? And the answer to that is going to be an eco-biodevelopmental approach. And that means we're going to have to think about our environment, our biology, and the ways in which we develop from childhood to adulthood to understand how those social inequalities get under our skin, how those social inequalities make us sick. So the first answer has to do with adversity and toxic stress. Our bodies are designed to respond to stressors in a really specific way. If you think about our ancient ancestors who are, we all originally came from Africa. So our ancient ancestors living as hunter-gatherers on the African savanna, they developed a bodily response that let them survive the kind of stressor that was most prominent in that era. And that was the stress of a predator, that you might have found a patch of berries and there's a bear that wants them, or you might have found a fallen zebra that's injured and easy to butcher, and there's a lion that would like to have it for lunch. And by the way, I pick lions and zebras because everything I know about lions I learned from the Lion King, and Mufasa told Simba that they eat zebras. So that tells you the extent of my zoological knowledge. Okay, so think about it. If your body in that context senses, I don't have control in this situation, what happens is that your hypothalamus, your brain, sends out these electrical signals that says, uh-oh, be on alert. You don't have control in this situation. That signal is translated by your pituitary gland into a hormonal signal that goes to your adrenal gland. And the adrenal gland produces cortisol, which is this stress hormone that lets you fight or flee in that situation. It's assuming that your stressor is acute and episodic, meaning it's happening right now and it's going to be over in a minute. Because think about it. If you're being chased by a lion, you either get away or you don't. If you get away, you're not stressed anymore. If you don't get away, also not stressed anymore. And by the way, that joke usually works in public, and I have no idea if it works on Zoom. Okay, so your body is designed to respond to that kind of stressor. It's quick and then it's over and you go back to baseline again. That cortisol raises your heart rate so that you can oxygenate blood more effectively. It releases a coagulating agent into your blood so that your blood will clot and you won't bleed to death if you're injured. And it slows down how quickly you use up the sugar in your blood so that you've got a ready source of energy. How much cortisol you have in your blood is called your allostatic load. And we're designed to have a low allostatic load because the stressor goes away and whew, body goes back to normal. But the stresses of racism and the stresses of poverty are not acute and episodic. Those are chronic and systemic stresses. And that means that our body stays permanently in that activated state. The result of that is predictable. If you think about what goes with having a kind of constantly elevated heart rate, you can think about hypertension, cardiac disease. What goes with having chronically elevated blood sugar, diabetes? What goes with having chronically elevated coagulating agents, things that are, making your blood thick? Stroke, right? Blood clots and stroke. And so if you think about the diseases that have the highest rates of disparities right here in Memphis, stroke, hypertension, infant mortality, diabetes, all of these are driven by the fact that the stresses of racism and the stresses of poverty are so chronic and systemic. Oh, this is a joke about growing up in Indiana and eating brain sandwiches, but I don't have time to tell it later if there's time. Okay. Second, weathering and the life course perspective. So your blood sugar stays high all the time because you've got this high allostatic load. That explains a certain level of disease. But here's another thing that happens. Your body staying chronically stimulated by that fight or flight response will also damage your body at the cellular level. It'll produce inflammation. Your body will throw off inflammation markers like C-reactive proteins. We can actually draw blood, find out how much inflammation somebody has in their body, and that will tell us how stressed they are. The thing about that constant inflammation is that it will wear your body down. Now, over time, as we age, that weathering happens kind of naturally. And the image here of weathering is sort of imagine a home that's painted and the front of it takes the brunt of, the wind and the weather, and the back of it is protected from that. The front of the house will age more quickly than the back of the house will. It's also true of our bodies that those who have chronically elevated allostatic loads will age faster than those who have less stressful lives. And that aging faster means some of us will experience the diseases of old age at a younger age. So if you think about two 65-year-olds, one of them still might be running marathons and the other can barely make it across the room. There you've got an example of how weathering works. I should have mentioned infant mortality. Cortisol is also the hormone that prompts uterine contractions. And so having a chronically elevated allostatic load will also lead to premature births. And that may account for why we get that higher infant mortality rate between Black and white. And then finally, biological embedding. I'll touch on this one just very briefly. So you're born with a genetic code. But the thing is that genetic code isn't fixed. Your genes respond to your environment, and your environment can trigger what's called an epigenetic shift, meaning that your environment causes your genes to express themselves in a certain way. There are certain kind of acute stressors in childhood that can trigger an epigenetic shift that permanently tells the body, you'd better stay in a fight or flight mode. And so children who experience what are called adverse childhood experiences, some of you may have heard of ACE scores, children who experience those ACEs might be set up for a lifetime of chronic illness. And by the way, I think this is a place for us as faith leaders just to recognize that what we're doing to children at our borders right now, separating them from parents, having them live in unhygienic conditions, inadequate sleep, poor hygiene, locked in cages, that's a moral affront in so many ways. But it is also a moral affront that will be with us for decades as those children suffer this epigenetic shift that biologically embeds a heightened allostatic load. Okay, now what I'm going to do is briefly ask if there's anything about that I can clarify before we move into the conversation about systemic racism. Are there, let's see.
Just inviting everyone to use the question and answer feature if you have any questions of clarification for Dr. Hotz. And
okay, I promise you're going to think of some. So what I'm going to do is move us into the discussion of systemic racism, and then we'll come back for another set of questions and answers at the end, but also be aware that 2 weeks from now, we have an extended conversation about this material. So we can definitely cover more of those at that time. Oh, but now I'm just seeing, how many years was the life expectancy gap? That was 13 years from Soulsville to Collierville, 13 years. Yeah, and that was data, by the way, that was in the commercial appeal just about a year ago. Okay. Someone is asking what the work of liberation means, and I am not going to answer that because you're pastors. That's your work. All right. I want to have that conversation with you, but that's not a question you can sort of answer with a quick bit of data, is it? All right. Now, this time, what I want to do is take all that information you just received and help us think about it from a social perspective rather than from a clinical perspective. That was pretty clinical, right? We're thinking about C-reactive proteins and allostatic load. That's stuff doctors do. This piece is stuff pastors do. And so I want us to think about what I'm going to call agency bias, and I'm going to contrast it with something called structural competence, which is a term I am borrowing from one of my favorite scholars, Dorothy Roberts. All right. Here we go. All right, so one thing that you're going to want to know about me, a little bit about my background. I grew up in the 70s and 80s in Southwest Indiana, so I'm a Hoosier girl, and in a rural area, working class. And, it's funny because growing up in Indiana, I was literally taught that we were exempt from racism, that we were on the right side of the Mason-Dixon line, and all of that racism belonged to people just to the south of us. Now, that's bizarre in a lot of ways. First of all, we were like 5 minutes away from the Mason-Dixon line. And second, that area of Indiana actually has a higher per capita Ku Klux Klan membership than this area of Tennessee does. So, I was sort of indoctrinated from childhood with this idea that racism was something other people had a problem with. And I was also taught this history in my school that said we had slavery and that was bad, but then there was Abraham Lincoln and yay, it was better. And then somehow by mystery, things weren't good everywhere. And so we needed Martin Luther King and yay, everything's better now. Many of you probably learned a similar kind of history of the US in school as well. And so we were sort of taught that we had been born into this era with a blank slate, that everybody started at the same place in life. And if you didn't do well, it was your own fault. And I'm going to call this agency bias, this tendency to explain things by blaming individuals. And so most of my friends from high school, those who are still living, are they're working as cashiers at convenience stores and Walmart. A few of them drive trucks. One is in law enforcement. It's not a group that I would describe as affluent or as having high socioeconomic status. And yet they'll post memes like this on Facebook. I'm still connected with this group on Facebook. And, except for posting a picture of your grandchild or your puppy, this is the kind of thing that gets all the likes in the world. You're one decision away from a totally different life. Factually, that's just not true. Good studies show us that without some kind of deliberate external intervention, it takes about 20 years with nothing of significance going wrong to work your way out of poverty. Let me just repeat that. To work your way out of poverty, to make a series of good decisions that get you from poor to stable, takes 20 years in which your car doesn't break down, you don't get seriously ill, there's not a pandemic, you don't get laid off. About 20 years to get from poor to stable, minus unless there's some kind of deliberate external intervention. So you're really not one decision away from a totally different life. Another way of naming agency bias is to call it the myth of meritocracy, the myth that we get what we deserve. And here's another one of these memes. Your life is the result of the choices you make. If you don't like your life, it's time to start making better choices. The thing about Whether your life is the result of the choices you make, though, is more complicated than that. I mean, certainly we make decisions that have good and bad consequences. And believe me, I'm regularly telling my first year students at the college, you flunked your biology exam because you didn't study, right? Certainly our choices have an impact on our lives, but our lives are not singularly the result of those choices. So another study, the top predictor of being a success as an entrepreneur in the US is having been born to affluent parents. Why is that? Born to affluent parents, you can afford to take a big risk. Opening a business is a big risk. If you lose everything and the business goes bust, you come from affluence, worst case scenario is that you got to move back in with your parents for a couple of years while you rebuild. But if you are from an impoverished background, first, you may not even have the capital to start that business. And second, if you do and lose it all, it means destitution for you, for your family. It means that you become a hardship for other people you're related to who are also struggling economically, who now need to provide support for you. And so you're less likely to take that risk. That means if you're affluent and you become an entrepreneurial success, good for you, right? That's great, but you didn't do that all by yourself. All right, to contrast with the myth of meritocracy and the idea of agency bias, we're going to talk about structural violence and structural competence. Structural violence is a term that Paul Farmer uses. He's somebody in global health that describes physical and psychological harm resulting from exploitative and unjust political, social, and economic systems. So physical and psychological harm that comes from injustice. Structural competence is what we need to learn to get ourselves away from the tendency to blame people when bad things happen to them, to get away from the tendency of agency bias. And by the way, this is a presentation I do for doctors a lot. And one of the things we talk about is how if your patients feel that you are judging them or blaming them, you're going to break that relationship so badly that they're not going to be able to receive whatever healing you have to offer. And I think that this is actually something that pastors, I think, could do a good job coaching physicians about. If we could get physicians to accept coaching from pastors, I actually think that would be a really useful way forward. So to understand the relationship, what I mean by agency bias, I'm going to talk a little bit about social location. Where are you from? And I'm going to use this geological metaphor to describe the difference between two different social locations. Chad is white and he lives in Collierville. And he is, by the way, a construct of my imagination. This isn't an actual child. And his metaphor is this mesa. So this is a big flat-topped mountain. Geoffrey is an African-American child whom I actually knew. His name is not Geoffrey. He's now about 18 or 19 years old. He was 8 when I met him. And I want to make him live in Soulsville because that would work beautifully with my first slide. But he's actually from Binghamton. And in my imagination, I can't switch his neighborhood. So Geoffrey in Binghamton, and he lives on top of this rock spire, which is called a hoodoo. And I think that's just a really fun thing to say, hoodoo. So Geoffrey lives on his hoodoo and Chad lives on his mesa. And what we want to do is figure out why they live in those two different places, because we know this is going to make a big difference in their health downstream. To do that, we're going to think about where we stand. And I'm going to introduce you to a little bit of vocabulary here. First, the difference between life chances and life choices. How many chances you have in life? How wide is your mesa is a good way of asking that. How wide is your mesa? Those are your chances in life. And then your choices in life, that little guy up there, that little stick figure. By the way, I drew that myself and I'm really impressed with myself because I'm not really technologically competent, but I did manage to draw on a slide. So, and you see my artistic skills too. So here's this little stick figure guy making choices, and there he is up on top of that mesa, and he can make all kinds of choices. He can make lots of mistakes before he suffers the catastrophe of falling off the edge of the cliff. If he falls off the edge of the cliff, it's going to take him 20 years to climb his way back up again, right? So, but he's got a lot of room. He can make a lot of mistakes. He's got lots of chances to make good and bad choices before he suffers catastrophe. Geoffrey, on the other hand, lives on this rock spire. And here the language, life choices, life chances, another way of saying that is structure and agency. Agency are his life choices. How many mistakes can he make before he steps off the ledge of that rock spire and collapses to the bottom? How much structure does he have to support him? I think the short answer to that question, what is the work of liberation, is how do we make that structure wider, right? Maybe the work of liberation is figuring out why Geoffrey doesn't live where Chad does, not in Collierville, right? But why doesn't he have that big, wide base of support? I'm not advocating moving people to suburbs. All right, so this is really about how many mistakes can you make? And we're going to use a root cause analysis, which is a very simple process of asking, why is it that way? And we'll just keep asking, why is it that way until we understand why Chad has the mesa and Geoffrey has the spire. So we will start with family of origin. Very briefly, the reason they have anywhere to stand at all, the reason Geoffrey's on that rock spire and not down in the pit, is because he's got a great family of origin. He's very fortunate. He's got a 2-family household. You don't have to have a 2-family household to have a good family of origin, but Geoffrey does. He's got some extended family in the area. He's active at his church. He likes math. He doesn't have, all of the advantages. His parents paste together 2 and 3 part-time jobs, so they can't be at home when he gets home from school. They can't afford extracurriculars for him. But, he's got that base of support, and that's why he's got anywhere to stand at all. Now, the question is, why does Chad have more than that? So we're going to start in 1935 with Social Security. And you're thinking, how is she going to get us from 1935 to 2020 in the next 15 minutes? This won't be painful, I promise. Well, it's going to be painful, but it won't take very long. Social Security started in the middle of the Great Depression as a way to help our elder citizens avoid falling into destitution, but also to help their children build intergenerational wealth. So if a parent who was employed had to take care of both children and parents, then their resources are stretched thin. But if your parents have Social Security, then you can devote all of your resources to your children, and that helps to build up intergenerational wealth. 1935, they could not get the bill through Congress. A handful of senators from the South refused to vote for it if their African-American constituents were going to be eligible. And so they changed the Social Security bill so that you were not eligible for it if you worked in farm or domestic labor. Here's the deal, 1935, the United States was 90% white. Can you imagine that? 90% white. But 26% of those who were ineligible for Social Security were African American. So you see this enormous disparity between white and Black who got Social Security. And that 26% is a misrepresentation of this part of the country. You go to a place like Vermont, it's 98% white even to this day. But the Mississippi Delta has always been a densely concentrated area of African Americans. And so right here where we live, you had some of the greatest areas where people were unable to build up intergenerational wealth. So Geoffrey's family gets this benefit, Chad's family gets this benefit of Social Security, and their rock spire just got a little bit wider. Next, the practice of redlining, also from the 1930s. Federal Housing Authority made maps of all of the metropolitan areas in the US and ranked neighborhoods. This is a redlined map of Memphis. If the neighborhood had all the sort of assets that you would want in a neighborhood and it was considered low risk for public and private investment, it got the color green and the letter A. Anything less than that was B, blue. Risky was C, yellow, and high risk, stay away, was red, D. This map of Memphis, just to get yourself oriented, this green square right here is Overton Square. Here I am at Rhodes College, right? So I'm in this blue B area. This is the Evergreen neighborhood. Here you've got the affluent Central Gardens neighborhood. Here we're coming through Midtown, which is a B. This is Chickasaw Gardens, one of the most affluent neighborhoods in Memphis. That's an A. This is Orange Mound. You can see it was redlined. South Memphis is regarded as risky. All of downtown was risky. Now we're coming across Smoky City, Klondike, Nutbush, Berkeley, Binghamton, right? In other words, this map from the 1930s is exactly what Memphis looks like today. If you were redlined, you were essentially ineligible for public and private investment. And here's the trick. Even if you were a stable middle-class neighborhood, if Black people lived there, they automatically gave you the grade of D. So if you take a look at the housing stock in Binghamton, it was clearly a nice little middle-class neighborhood. Take a look at Orange Mound, our first historically Black neighborhood built for and by African Americans in the nation. Sections of Orange Mound were definitely solidly middle class. All of those are redlined, not because they were risky. They were redlined because they were Black. That's what the map of Memphis still looks like today. In fact, it's also what our disease map looks like today. This is COVID cases in May. And by the way, if you pull the map from today, which is on the Shelby County website, it still looks like this. I'm using this old one because it's visually less complex than the new one. So redlined, right? Here I am at Rhodes College, right about where this blue dot is. Here we've got Evergreen and Central Gardens in Midtown, right? Orange Mound, South Memphis. Here, Uptown, Smoky City, Klondike, Nutbush, Hyde. This is Binghamton. What you're seeing is that the places where we have our highest rates of COVID-19 infections are also the places that were redlined. Health and wealth go together. By the way, a high allostatic load also disrupts your circadian rhythms, makes it hard to sleep. Disrupted circadian rhythms will suppress your immune function, making you more likely, more susceptible to infectious diseases like COVID-19. And so that explains, if you see people who are wanting to blame African Americans for not being careful enough, they don't know what they're talking about. The problem is not how careful you're being, the problem is racism. I mean, you should still wear your mask and wash your hands, but that's not gonna fix racism. Okay, why is it that way? Notice what's happening. Chad's mesa keeps getting wider. He had the advantage of redlining. Redlining made his mesa wider. He got the advantage of public and private investment because he lived in a white neighborhood. Now we're going to look at Federal Housing Authority loans. In the 1940s, when soldiers were returning from World War II, the government instituted this practice of subsidizing mortgages so that people could afford to buy homes, because most people couldn't afford a down payment. So you could just put 1 or 2% down payment and you could get an interest rate that would be the same as if you had put down 20 or 30%. And that allowed people to build intergenerational wealth. You could buy a home, you could pay it off, you could pass it on to your children. Thing about FHA loans, though, is that between 1945 and 1962, fewer than 1% of them went to African Americans. And even as late as 2008, in the financial crisis, we discovered that subprime mortgages were being pitched to African Americans who were well qualified for other kinds of loans. So in our housing practices, Chad's mesa is getting wider. This means that his great-grandparents had Social Security and redlining. His grandparents had access to Federal Housing Authority loans. They're building up intergenerational wealth. Urban renewal. Short definition of urban renewal is that it's what happens when you knock down Black neighborhoods to build amenities that white people want. Let me give you an example. This is Binghamton. So this is where Geoffrey lives. What we've got here is Sam Cooper in yellow. This is Broad Avenue in green, and this is the Binghamton neighborhood. Here's the thing about Binghamton neighborhood. Broad Avenue used to be its main street. If you go along Broad Avenue, it still has all those old style Main Street storefronts. You know, there would have been a grocery store there and a hardware store, a pharmacy, a five and dime. It was very easy to walk from Binghamton to Broad Avenue. But when the Department of Transportation, which had subsidized all those loans that built suburbs like Collierville for Chad's family, well, people didn't want to live out there if they couldn't easily get into the city. And so the government began building these major highways. And they put those major highways right through Black neighborhoods, overwhelmingly put through Black neighborhoods. I've got a poster from the 1960s that has a line of car, and on top of it, it says white man's road, and underneath it says through Black man's home. So I've got to add that to this presentation. So what it means is that Geoffrey's family no longer has walking access to the resources it needs to stock the household. Now you've got to get on a city bus and go pretty far away to get to a grocery store. And can you get back in August before your milk spoils? But white residents who have now moved out to places like Germantown and Cordova and Collierville can easily get access to town coming through on I-40. Sam Cooper was supposed to be I-40. A lawsuit went to the Supreme Court in 1971. They stopped it before it went through Overton Park, but they didn't stop it, of course, before it went through Binghamton. So this is an example of urban renewal, right? Eminent domain. You buy up all of those homes along Sam Cooper, which were cheap to buy because redlining had suppressed property values. You knock them down and you put your highway in. Why is it that way? Why? See, Geoffrey's still on his rock spire. He's still got his family. He's still got his people. But Chad is getting all of these other advantages. His great-grandparents had Social Security. His grandparents had redlining and FHA loans. His parents are protected by the Environmental Protection Agency from hazardous wastes. But Geoffrey's family is not protected from hazardous wastes. The city of Memphis has more EPA Superfund sites than any city in the US. We have 173. We are also one of the most densely populated African-American cities in the US. Here's one of them. This is the Memphis Depot. It's in South Memphis, down by the airport. The areas in green are neighborhoods that are 90% or greater African-American. And this is a trend we see nationwide. Everywhere we put our hazardous waste sites, everywhere we put our solid waste processing facilities, it's always in neighborhoods of color. In fact, being a Black neighborhood is a stronger predictor of having a hazardous waste site than being a poor neighborhood. So a poor white neighborhood is less likely to have something like this than an affluent Black neighborhood is. This is MLK Riverside Park. This is kind of like the Overton Park of South Memphis. It's really hard to get into because it's bisected by I-55. The environmentalists who wanted to protect Overton Park didn't care about MLK Park, which at the time was just called Riverside Park. There's lots of asphalt in there. You pretty much have to drive to get there. But here I am standing in the middle of MLK Park looking to the south, and this is a picture of the Valero refinery. And all of the particulates coming out of that smokestack, because of prevailing wind patterns in Memphis, are going to 38106, which has our highest prevalence of asthma in Memphis. In fact, I have a map of asthma prevalence in Memphis, and it looks exactly like the COVID-19 map. Oh, that's exhausting, right? When we ask why is it that way, on and on and on, what we find is that it's not the individual choices that Chad or Geoffrey make. It's a history of racism that produces huge chances for somebody and limited opportunities for others. So overcoming agency bias, this tendency to blame individuals, is partly about learning where we stand. What's under my feet? Where do I stand? What is the story of this place? And even though I don't expect you to walk around with a history of US housing policy in your head, I'm a geek, that's what I do, right? You can learn to say, I don't know the story, but I'll bet there's a story there. All right, let me be quiet. We still have just a few minutes, just about 10 minutes or so. I would love to hear what you are thinking and what you would like to hear more about.
Dr. Host, thank you. As we wait for those questions to come in, as I know folks are typing, I just would love to hear your thoughts just about how do we begin to use this information to hold one another and sort of the structures that govern and guide us accountable.
So the first thing is that I think pastors are ideally equipped for this work because you're good at telling stories. And what we need is not more data. We need better stories. We need to learn how to tell this history in a way that people will listen to, in a way that they can hear, so that they begin to reframe. So when a referendum shows up on a local ballot about, whether police should have to live in Memphis or not, people have some framework for thinking about that. So that when politicians are proposing, let's build a road here, or let's build a stadium, or how much are we going to fund public transit? People need a story to help them frame that so that they understand what's at stake. So I think the first thing is learn to tell the story.
Thank you. I haven't seen a question yet, so I'm going to continue sort of posing my own. And I do want to recommend that for folks, and we'll send this out there in terms of story. There's a great book that I read, and that as I'm a part of the Presbyterian Church USA, we've read it as a denomination or commended to the denomination, called Waking Up White by Debbie Irving, which I think is a great place to start, particularly for our white clergy members, but indeed for everyone to understand much of what you were talking about and continue to go deeper. But I'd love to know your thoughts on how can pastors engage in this work? What might that look like for you, or in your opinion, especially white pastors, as they're speaking to their congregations and even a diverse audience?
Yeah, I think the burden of this work should fall to the white community. Asking African Americans to take primary responsibility for educating us about racism as its impact is a way of magnifying that challenge. So I'm really glad to see that somebody's asked that question in the chat, that how can white pastors do this work? So the first thing I would say is that you need a deep dive, right? You need to educate yourself. So I would start like a book club with other pastors where I can make recommendations, where you read things like Robin DiAngelo's White Fragility, Rothstein's The Color of Law. If you haven't read Michelle Alexander's New Jim Crow, you need to look at that to understand mass incarceration. I would start with educating yourselves and then getting really comfortable talking about race. We have this kind of phobia about just naming, here's what it is, and just saying, here's the thing. And so that's going to take, you got to get comfortable with it. You got to build up your courage and then ask yourself, okay, where's my congregation right now? What are they capable of hearing? And then I would also say, if you can, partner with Black congregations. We have no shortage of Black congregations in Memphis, right? If you can partner with Black congregations, maybe do pulpit sharing, have African-American pastors come and teach your congregation if they're willing to do that. And I'm just going to name this, you need to compensate that, right? We've seen this enormous disparity in how wealth got built in white communities and not in Black communities. And that means that we need to make sure that we are compensating African-Americans when we ask for their labor. And then I would also say, if there's any way to do some resource sharing between congregations, that would be a great idea. Do I have an idea of how to assess what your white congregation is capable of hearing? Yes, I do. And I'm actually going to recommend one of my colleagues for this. So Dr. Dwayne Loynes here teaches in our health equity program. He teaches our course called Developing Cultural Humility. And he has a cultural intelligence instrument that he uses with groups where you kind of take this, it's like a quiz, you take it before and then you do cultural humility training and then you take it after. And he's had really good luck working with white congregations on that. His field of expertise is actually policing. So now I feel like a bunch of pastors are writing down his name and he's going to end up with, 40 speaking invitations. He's used to that. He does a lot of speaking around town. He's terrific. And so I would think the cultural intelligence material from Dr. Loynes would be terrific. Anyone who wants to be in touch with me, I'm happy to receive your questions. Rhodes College has actually produced a whole series of lectures. The one you just watched is one in that series. And you could have people in your congregations watch those in their own time. They're recorded. And then you could get together and do, have the faculty member come in and do question and answer, or you could just make it a conversation. Seeing how people respond to videos like that might be a good way of assessing where your congregation is. I'm happy to receive that. One other thing I'm going to put a plug in for Rhodes. Right now, I'm conducting a research project with Black pastors where I'm having conversations with Black pastors about experiences with medical racism. And so we're also trying to kind of gather that kind of information to think about how we can educate white physicians. By the way, if any of you would like to participate in that study, be in touch with me. I can get you my contact information. And I'd love to facilitate a conversation with you or with a group of you to help get those stories about medical racism out there.
Thank you, Dr. Hotz. I have one final question, and it's really just about how you ended. If you could just elaborate just a bit more on what are some of the ways that you've seen racism in healthcare affect the life of a congregation, both Black and white.
So the most basic thing we see, and we see a lot of it, is that Black communities mistrust healthcare providers. Healthcare providers often think that this is because Black communities are superstitious. It's not. It's because Black communities have good memories and because they have plenty of experience with not being taken seriously, with not being listened to. And so I think the primary place we see this showing up is with a lack of trust. The truth is, just at a very human level, it is easiest for us to form close sense of affiliation with people who share a lot in common with us. The racial divide in the US is so wide that physicians who are primarily white and affluent have a really hard time relating to high-income African Americans, to low-income African Americans, to low-income white people. They don't know how to form those bonds. And they also tend to lapse into this agency bias that blames people. And so the main place I've seen it is there's just this huge number of stories out there. When I ask physicians about medical racism, they'll be like, oh, well, we know about the Tuskegee experiments. That was a really long time ago. It ended in 1972. It wasn't that long ago. But, they'll think, okay, that's over, that's past. But, the truth is it happens every day, and it's in the little microaggressions, but it's also in some really galling present day instances of medical racism. And so part of what I'm trying to do with this study is gather those narratives and begin educating physicians about these are the things you're doing that say to your patient, I don't believe you, I don't trust you, I'm not listening to you, I don't take you seriously. That's kind of what we're working on.
Thank you. And that work is incredibly important, as indeed this conversation has been, I think for me, refreshing to remember the many ways that, and I say refreshing intentionally, refreshing to remember that this is a structure that has been built and indeed it can be dismantled. And in terms of learning about the dismantling and sort of where do we go from here, I encourage everyone who is on the webinar now to join us in 2 weeks on Thursday, September 3rd, 11:30. Dr. Hotz will be back with us, as well as a number of other clergy persons to just sort of discuss all that we've laid out here and think about how it lives within the Black community and where we're going from this point forward. You will get that link in your email, along with, we'll get with Dr. Hotz to get all those resources that she mentioned to push it out to you. So please be on the lookout for that message. And indeed, we are grateful that you took some time this afternoon to be with us. And Dr. Hotz, do you have any other final comments you'd like to offer us?
I'm really grateful for the opportunity to speak with you. I'm looking forward to next time when I'm going to be quiet and listen.
And I will end our time with just a quick word of prayer. Let us pray. Eternal God, who stands outside of the beginning and the end. Eternal God, who is beyond all of our imaginations, all of the things and the ways we have built to govern ourselves. We ask that you would have us to come fully to know this information, that you would take all that was said, all the questions that were asked, all those that we are still formulating in our minds, and use it to fuel us forward as we continue to build your beloved kingdom. We thank you for this time, and we ask that you would give us a peace to understand that you are at work with us, that you would make us uncomfortable enough to bring that work to a completion. This we pray. Amen.
Amen.
Okay. Thank you again, Dr. Hotz, and everyone. We will see you in 2 weeks. Have a great afternoon.